Okay, so thank you very much for joining me today. Hi everyone, I'm Dr. Mahin Ashraf and welcome to Imaging Study. Today we are going to discuss about 5 ultrasound cases. Usually in my recent ultrasound case series, I tried to share 5 cases with you and then I tried to give you an idea about any different topic like you have seen before, like fetal position, hepatic segments, whatever. But today I'm just only trying to share only 5 cases because I have chosen some large cases, and after these 5 cases, it will be very difficult to concentrate on any topic that I want to teach you. So that's why we are just trying to show you 5 cases today. And hopefully on our next sessions, we'll try to add bonus part. So anyway, thank you for joining me. Assalamu alaikum. Walaikum assalam. So let's start with the case number 5 already. Case number 1. So already we are late. Anyway, if you're new to our this program, we have a YouTube channel named Imaging Study. We try to share our contents there, and if you have missed our previous sessions, then you can easily get them on our YouTube channel. So they're already ready there, and you can just check whatever you want. We have already got around 62K subscribers, so we are waiting for that. And we have already uploaded 471 videos, some of which may be helpful for you. So anyway, let's jump into the session. If you have any question, you can just put it down on our Facebook Live, because my Facebook Live is already beside me. I can see who are trying to join and who are trying to comment. And don't forget to comment about your location, from where you are watching this video actually, because I see many people are connected to this content from very far away from my country. So that's very interesting and that's very appreciating actually, because we can see the participant country when we see the insight of this video. Anyway, so don't forget to comment down about your place from where you are trying to watch this content. Anyway, so let's start. So our first case, this is a 30-year-old female patient who actually came with dysmenorrhea. I think my previous session also started with a case of dysmenorrhea. Anyway, so let's see the uterus. This is a transvaginal ultrasound, and you see with proper prop position, the if you see the fundus of the uterus on the right side of the screen, or air from the indicator side, it's usually the retroverted uterus. So this patient also had a retroverted uterus, and the measurements look quite normal, nothing complicated here. And we also had some Nabothian cysts there. This is a very common finding when we do the TVS, so it's nothing fancy. So let's jump into the video. So here you can see this is the retroverted uterus, and here you can see some echogenic areas here. You see these echogenic areas? They're heterogeneous, making the myometrium a little bit heterogeneous. And if I freeze the image at this point, now you can see some hyper layered by layered appearance, or you may see some like a fan shaped shadowing coming here. So any heterogeneous echogenicity with some fan shaped shadowing or some echogenic stripes indicate it to be a case of adenomyosis. So let's see the image from different side. So you may miss this echogenicity, like it looks like quite normal, but even the uterus size is quite normal. So if you observe it a little bit carefully, then you may not miss that. So to see it properly, you may magnify the image a little bit. So I have magnified the image, reduced the gain. Now you can see this is the endomyo junction, and at the endomyo junction, you can see some tiny cystic spaces, which is very much confirmatory feature for the adenomyosis. So these are the tiny cystic spaces at the endomyo junction, as well as you can see the echogenic heterogeneous areas within the myometrium. You see the cystic spaces here also. Okay, so let's see it from different angle, and you can see these tiny cystic spaces with heterogeneous myometrium, indicating it to be a case of adenomyosis. So here another view, just I'm trying to look it from different angles to see whether there is any fibroid inside the adenomyosis. Because remember that whenever you get adenomyosis, don't be crazy and end the diagnosis. You try to search for the fibroid because it's a common association. Also, if you get the fibroid, you try to search for adenomyosis, vice versa. Okay, so here's the ovary. We checked the ovaries of this patient. Both ovaries were normal. So I don't know how you measure the ovary from two images or one images. Whatever the measurement is normal. So I have nothing to worry about the proper technique. So these are normal ovaries, and the patient had the adenomyosis. So this was a case of uterine adenomyosis. So it was an easy case. I was just waiting for the people to get joined because next four cases will be a little bit complicated. So let's jump into the case number 2. So this is a 32-year-old male patient. I think this is a case from this week from my practice. Anyway, so this is a 32-year-old male patient who came with a right hemiscrotal swelling. So it was gradually increasing in size, and he complained about mild pain. I was a little bit confused because when I saw the prescription of the clinician, he actually clinically diagnosed it as right-sided hydrocele. I don't know why he actually thought about the hydrocele. Anyway, let's jump into the case. So this is the left testis, which is the normal side for the patient. The testis was a little bit smaller in size, so it was a 3.1 centimeter in length. In comparison to the other testes or age, it's a little bit smaller. The volume is around 5 gram or cc. The patient also had varicocele on the left side. I don't know which classification you follow, but we usually follow the Sertasi classification. You can easily search it as varicocele staging or grading. You can find it on Google. So according to Sertasi classification, if you see prominent, that means more than 2 millimeter diameter, less than 3 millimeter diameter, pampiniform plexus of veins in cum respiration at the lower pole with reflux, it goes in favor of grade 3 varicocele. You see, if it is only available on the upper pole, you'll go for the grade 2, and if it is already in the lower pole, you go for the grade 3, and if it is more than 3 millimeter with reflux, you will go for grade 4, and if there is reflux in cum respiration, we go for the grade 5. And in case of grade 1, we just don't see any dilated vessel, rather the vessels are normal, and at the upper pole or cord level, there is reflux in valsalva. Especially if you make the patient in standing position, it's quite easy to see. But in supine position, you may sometimes easily visualize these findings also. So anyway, that's a little bit complicated. So I don't want to go for the varicocele in this case. So let's jump into the right testis, which we are actually looking for. Now, this is the right testis. On first impression, it doesn't look normal. I was a little bit confused because it looks like some cystic spaces within the testis. Okay, so we measured the testis. It's apparently normal in size in comparison to the normal patients, but in comparison to the other testis, it's a little bit enlarged. Okay, so it's a 40 millimeter or 4 centimeter, which is normal for a normal testis size. But it is enlarged for this patient because the opposite testis is smaller. Anyway, so this is the right epididymis. It doesn't look like epididymis, rather it looks like the testes. I was a little bit confused because when I looked at this picture, I thought that, oh, this is the testis and that might be the epididymal head or something like that. But this is not the testis. This is the epididymis. So let's see the video. So here's the real-time view. And now you can see this one is the testis. You can see the sharp margin here. You can separate it from this methylation. and this is the large epididymis. Now, what we are actually watching here, we're seeing the testis and epididymis both look like a similar ecotexture, and you can see multiple cystic spaces. The echogenicity is increased. Overall, it appears like a mass lesion. Okay, you can see some hydrocele or fluid collection also. Okay, so let's look from different view. Now we have put the curvilinear transducer. With curvilinear transducer, even you can see these lesions like the testis and the huge sized epididymis on the right side. So they're actually compressing the left one. That's why the left one is also having some situation and getting smaller in size, I think. Okay, so there's some cystic spaces, whether these are necrotic spaces or something like some malignancy going on here. Okay, so let's jump into the linear prop view again. So we are just moving the transducer here and there to see whether there is any definite abnormality or the whole of the testis and epididymis is involved. Again, if you see sometime this type of lesion, like the whole testis or whole epididymis is showing the Swiss cheese appearance or diffuse cystic appearance, you definitely should search for the calcification. Can you see any calcification here? I tried to search for the calcifications. There is no calcification present here. This is a very important finding, and you definitely should mention that thing because it will differentiate most important two differentials. Okay, so let's put the color Doppler. So here I have put the color Doppler. The normal testicular flow doesn't look like that. You see your 5 fingers here. This is the normal testicular vessels. Like intratesticular vessels will come like this pattern, like a finger pattern. But here you can see, yeah, there are some finger pattern vessels, but some disorganized vessels are also present. This will happen for the epididymis also. In normal epididymis, we don't see any prominent flow in our regular setting. So, but here you can see different type of vascularity is seen here. This is actually a disorganized flow within the epididymis, which is a little bit unusual, and they actually indicate it to be a mass lesion. So let's jump into the view again. So just going upwards, you can see the vessels are a little bit getting enlarged because they are getting compressed by this mass lesion. But I checked it with the Valsalva. There is no reflux present on those pampiniform plexus of veins. So there is something abnormality going on, which is very concerning, I think. So I don't know why my clinician thought it to be a hydrocele. I don't know. Anyway, so here's the different view. I have changed my preset and I use this preset. This is a musculoskeletal ultrasound preset. This preset is very good to search for any tiny calcification. So I made it myself. So that's why I know that I am using it for searching for the calcifications. So there is no calcification here. You can see only the increased echogenicity of the testis and similar echogenicity of the epididymis with diffuse cystic changes. Okay, so here's another view and you can see diffuse cystic changes. You can see some hypoechoic contents here also. This might be thrombosed veins or there are so many ducts, so they got changed and got clogged or something like that. So whatever. So last view. So here we have put color Doppler on this setting and you still can see the good amount of vascularity both from arterial and venous flow. Okay, so here's the picture, last picture. You can see this is the testicular mass, or the whole of the testis has converted into the mass. And you can see the epididymis, which apparently looks like a large testis. So what's the summary of this case? Now, if you see anytime diffuse cystic change of testis or epididymis, it becomes swollen. There is no inflammation, but you see the disorganized flow. So you think about the malignant lesion here. This is a young patient, okay, 32 years or something like that, I think 32 years old. So what malignancy can it be? if you see tiny calcifications or punctate calcifications or microcalcifications, whatever, you go for seminoma. That is the commonest one. But here is no calcification present. So this is a very important feature. If you don't see any calcification and you see this type of diffuse cystic change, these are actually mixed germ cell tumor. You know, the histopathological diagnosis of mixed germ cell tumor. So we call it, we don't say mixed germ cell tumor. The histopath will say that. So these are actually non-seminomatous germ cell tumor, you know. There are many non-seminomatous germ cell tumors. So one of them is the mixed germ cell tumor. So this should be the mixed germ cell tumor. So we'll end it as the right testicular and epididymal multicystic mass lesion. But after histopath, you will definitely get it as mixed germ cell tumor. Okay. So it's a very uncommon case, I think. Many of you may see or not. So hopefully this will be helpful. Oh, okay. So uh, let's jump into the case number 3. So there's a 9, just we need to decrease our stress. So let's move to the NICU. So this is a 9 days old neonate who came with a history of preterm delivery and the birth weight was only 1 kilogram. So that's not good. And obviously there is a perinatal asphyxia. So let's see what we have got on ultrasound. So here we have used the sector transducer, that is the phased array transducer, which we use actually for echocardiography. It's a very good transducer to see the intracranial structures, you know, the brain and other areas. So here you can see the sagittal section and you can see the ventricle, lateral ventricle is dilated. Definitely it's dilated. Okay. So I hope the corpus callosum is present, but this is not a good view to say that. But overall, nothing else here. So here you can see the coronal section with the similar transducer. The resolution is not very good. Make sure this is a very tiny head baby. So the sector transducer won't give you a very good resolution because it is a low frequency transducer. You need to use high frequency. So here you also can see the lateral ventricles are dilated. The third ventricle is also dilated. Let me freeze the image. Let me show you the third ventricle. This is the third ventricle. It is also dilated. So okay, nothing else here. So we need to change the transducer, I think. So let's look at the view from the eggshell section. So now on the eggshell section, I don't think the view is quite normal. Sorry. So here you can see the third ventricle here, but the surrounding brain parenchyma doesn't look normal. You can see some extraventricular CSF space here, which should not be present. So the overall brain parenchymal echogenicity is very much increased. So, but it is diffusely increased and a little bit heterogeneous. So we definitely should end the diagnosis with linear transducer. So let's see the view on linear transducer. Here on linear transducer, you can see the overall brain looks heterogeneously echogenic. You see the ventricles dilated. That's not the important thing. You see the periventricular. This is the this is the extraventricular CSF space, which is also dilated. Okay, this is not the important thing. The important thing is that you can't see any sulci here. You see, there is no sulci here. The overall brain looks quite smooth and grossly echogenic. There are some cystic spaces possibly there, which might be the feature of leukomalacia. This is not important for me right now. But the overall brain looks echogenic and heterogeneous. Okay, so let's see it from a different angle. So now I'm using the linear transducers to see the area. If you look carefully, this is the choroid plexus. You see some echogenic areas here also. So there are some septations or something like that. So this patient definitely have intracranial hemorrhage. That's obviously present. If you look carefully, you may find that also. But I'm not looking for that. Whenever you see this type of heterogeneously diffuse echogenic brain parenchyma, that is the cerebral cortex, this is actually the case of diffuse cerebral infarction. It's not a big diagnosis. The main big diagnosis is that this is the feature of brain death. Before death, or just when the patient is on ICU or in ICU, whatever. We do a CT in those patients, and we check the brain parenchyma, the overall global echogenicity or uh, density get changed, and there is no presence of sulci. So this is the feature of brain death. So this baby is having brain death. So we say the clinician that this baby won't survive for several hours or something like that because there is also already brain death. So I think they just declared death after 1 hour. Okay. So this is the typical appearance of cerebral death or brain death. You see, no sulci, diffuse cerebral ischemia. Okay, so this is a case of cerebral infarction, diffuse cerebral infarction, and there is heterogeneously increased echogenicity with ventricular dilatation and effacement of sulci. Okay, so this effacement is a very important feature, and the baby will definitely die very soon. Okay, so this is a brain death. Now the case number 4. Okay, so these are, we always love to show you the pregnancy cases and complicated pregnancy cases. Okay, so this is a 19-year-old female patient who came to my chamber this week with a history of amenorrhea for 8 months. And there was suspected cardiac anomaly. I was very amazed because this patient was sent to me. If you're from my country, this patient was sent to me from Pabna. It's far away from the capital. And it's very interesting that on that area, two doctors made the diagnosis. So it's very crazy because we didn't expect to have a good diagnosis from an area far away from the capital. But they made a very good diagnosis. Just we tried to, sorry, so just we tried to add some several points to the diagnosis. That's it. So let's see what we have got on ultrasound. So here's the picture. Now you can see the baby is around 29 weeks of gestation. The AC is slightly lower, but nothing to worry right now. We just want to go for other findings. So here you can see the amniotic fluid index, which is also within normal limit. And the fetal heart rate was also good. So we are expecting cardiac abnormality, but the heart rate is quite good. So we are very happy. But here's the picture. You can see the baby looks quite good. The face is excellent, but we didn't show this face to the mother because we are expecting something bad future. So we just took those images. Usually when we find the baby going to die, they usually give us very good pictures. Okay, so let's jump into the heart. So we saw that on previous scans, the clinicians or the ultrasound experts made opinion that they were a little bit confused about the four-chamber view. Those were not good. They were not satisfied with the three-vessel view and the arch view or something like that. So uh, let's see what we can get. So the heart was in the normal position. Like, the baby was in cephalic position. I have shown you the fetal site determination technique on previous video. So if you have missed that, try to search it on our YouTube channel. You'll get that. So if the baby is on cephalic position presentation, then clockwise it will be the left side. So this is the left side of the baby and the apex is on the left side. So we are happy with the cardiac position. And apparently on first view, it looks normal in size. Okay. Now let's jump into the aortic arch view. You see very good arch view. There is no finding of narrowing. Rather, you can see this part, the descending part of the arch is slightly thinner or within normal limit than the ascending part. The ascending part looks a little bit dilated. So that took our attention. but the branches and everything looks quite normal. So let's see the video. So here's the first glimpse of the heart, and it's a magnified image. This is the fourth chamber like view. This is not the fourth chamber view. This is the or long axis view of the LVOT, the left ventricular outflow tract view. So I was a little bit confused. Okay, this is the interventricular septum like thing. Okay, but I'm not satisfied. Like if it is interventricular septum, then what is this? So things got a little bit confused at this moment. You see this structure here moving. This is the atria. You see this is the spine, and this is the descending aorta, and this is the left side. So this is the left atrium, this is the right atrium. And now you can see, if you look at the atrium, you can see some movement of this septum, which is a little bit unusual. The septum is pushed to the left side or to the left atrium, which is unusual. Usually we see this type of pattern in septal aneurysm. So this is the first point that struck me. Okay, let's look at another image. So now, okay, we have seen a very important thing. So you see, this is the interatrial septum, or the primum and secundum like thing. So it is pushed to the left atrium. Now, you see, this is not the mitral valve. This is the mitral valve here. So it is opening and closing. Where is the tricuspid valve? I can see that. Is this the tricuspid valve? On first impression, I thought that this is the interventricular septum. This is the tricuspid valve. This is not the tricuspid valve. This whole thing is the left ventricle. And you see this structure. This is the aorta. So this is the large aorta here. So that took our attention. Let me freeze the image. One thing is coming and going out. Just go a little bit backward. You see this structure. This is the pulmonary trunk. So that means this side is the right side. So okay, so we have got a very important finding. So this is the whole left side, and this one is the interventricular septum. So this one is the right ventricle. Let's look it further. Okay, so so this is a little bit of view of the inferior vena cava trying to enter into the right atrium. So okay, so it looks good, and you see this is not the mitral valve. This is the mitral valve. This structure is the septal aneurysm, and so this is the interatrial septum, or whatever you say. So this is bulged to the left atrium, and we call it the aneurysm. Okay, so we have got a very important finding. And now let's look at it from different view. Okay, so this whole part is the left ventricle, which is a little bit dilated, I think, but the overall heart size is quite normal. So you can see the aorta going from the left ventricle. So this is the left atrium. This is the mitral valve. Just see the mitral valve here. This is the mitral valve. So blood entering into the left ventricle, and this is the aorta giving blood towards the body. So where is the right one? So this is the interventricular septum, and this thin part is the right ventricle. So it is almost collapsed. So why it's collapsed? So let's see it from different angles. I'm not satisfied with the right ventricle. I just need to know where is the right ventricle and what is going to be happen. So this is the inferior vena cava entering, and this is the septal aneurysm. Okay, so we see all the time we are seeing the left one. Let me freeze the image. Just go a little bit backward. Okay. Just go backward. You see, this is the interventricular septum. This one, not this one. So, this is the mistake that we usually want to do. Now, if you look here, this is the tricuspid valve. Look at here carefully. This is the mitral valve. You see the mitral valve is opening, and now it's closing. Now it's opening. Now it's closing. Okay. But if you look at this part, this is the tricuspid one. Can you see it's opening or closing or something like that? It's just moving with the cardiac pulse, but there is no opening, closing, opening, closing. So this is the feature, and this is what's happening in this patient. So this is a case of tricuspid atresia. Now let's put the color Doppler. So here's the color Doppler. Okay, this is just a confusing one. Nothing fancy. We'll freeze the image on the proper one. Okay, let's freeze the image. Okay, you see, this is the blood entering into the ventricle, right? From the right atrium to the right, from the left atrium to the left ventricle. We are always seeing the left one. Now, the whole blood is going back to the body from the aorta. So this is the aortic flow. So it's getting the blood and just pushing it out of the heart from the left side. But where is the right one? There is no flow in the right ventricle. So the right ventricle is getting no flow because the tricuspid valve is not opening. It's just moving like this. So this is called the tricuspid atresia. You see, so everything is moving. It's like a ventricular septal defect, but this is not the ventricular septum. This is the ventricular septum. And this is the right at ventricle, which is not having any blood. So what will happen to the right atrium? Right atrium is already getting some blood. So when the right atrium is getting blood from the superior and inferior vena cava, they're just pushing the blood to the left side. So whole of the blood is getting back to the left side. So the this valve or this interatrial septum is getting aneurysmal dilated or displaced laterally to the left side. So the whole blood is going to the left and getting out through the aorta. Now, what will happen about the pulmonary trunk? You need blood to the pulmonary trunk and you need to supply the lungs. That's the important point. So we have the ductus arteriosus, so we can give the blood back to the pulmonary trunk through the ductus arteriosus. So that's what happening here. So let's put some 3D over here. It won't be very good 3D. Just you took the heart and just put the 3D over here. So 4-dimensional view. So this is the view. So let's put it on the tomographic ultrasound imaging. So we put it as multiple sections. Now you can see this is the aorta. You see the aorta is a little bit dilated. This is the ascending aorta. And this structure is the pulmonary trunk. It is quite narrow, but it's still showing you flow. So that's the important point. No matter what the color is, because it depends on the pulsation. So we'll avoid it in this image. So we'll see it on different view. So now you can see, let's look at the area. So we want to see, this is the aorta. You see, this is the aorta. You see there is something connecting to the aorta through this line. So this is the pulmonary trunk. You see this thin structure, this is the pulmonary trunk. It's giving a branch to the aorta, which is known as ductus arteriosus. And you can see also these are the pulmonary vessels here. So the pulmonary trunk is present. This is the large aorta here, so which is dilated. Now we want to see whether the pulmonary trunk is giving flow here towards the aorta or air from the aorta. So let's put some Doppler. It may not be well understandable from this view. So we'll use the still picture to see that. So here's the aortic view. You can see the on LVOT view, the aorta is giving blood out from the heart. And on this image, you can see this is the 3-vessel view like area, or I just try to take. So let me freeze the image a little. You see, this is having red color, but this one is the pulmonary trunk is showing you the blue color in a view. So you see, this is the aorta. So it is giving blood air from the heart, but now at this point, this one is giving blood towards the heart. So both should have similar directional flow, but the pulmonary trunk at this moment is not showing you the similar type of flow. But just after that, the pulmonary trunk will show you the red color, and it will supply the lungs from its blood from the blood that it got from the ductus arteriosus. That means the aorta is trying to supply a whole part of the body. It is giving some blood to the ductus arteriosus, and the ductus arteriosus is giving back the blood to the pulmonary trunk so that the pulmonary trunk can supply that blood to the lungs. Okay, so the baby is inside the mother's womb, so it's very safe position for him or her. But when the delivery will occur after birth, the lung will need a lot of blood, so the demand will increase. And at that time, if you close the ductus arteriosus, it will be a difficult situation. Again, the pulmonary trunk and aorta both doesn't have don't have the similar type of blood, oxygenated, deoxygenated. You know that. So that's why the lung will get a very difficult position or situation they have to face. So the baby will die very soon. So it's a complicated, critical situation right now. So what will you do? It's a 28 plus weeks of gestation. You have to be careful. So here you can see this is the arch of aorta. It is slightly dilated at the proximal part, and this is the ascending aorta and root of the aorta, which is also dilated. So because they have to work a lot. And you see the aorta in three vessel view. This is the aorta, this is the pulmonary trunk, which is narrow, and the pulmonary trunk is getting blood back, and then it is supplying the pulmonary through the lung through the pulmonary artery. So it's a little bit complicated. So aorta is giving blood to the descending aorta, and the descending aorta through the ductus arteriosus giving blood to the pulmonary trunk. Then pulmonary trunk is supplying the lungs with that blood. So it is not getting blood from the directly from the right ventricle, which should be, because the tricuspid valve is at stenotic, or there is no flow through the tricuspid valve. So this is the aorta, which is slightly dilated, 7 millimeter, and the pulmonary trunk is a steno. So stenotic pulmonary trunk is not very good for the management after birth. So this is the right ventricle, which is already collapsed. So here's the inferior vena cava entering into the right atrium. The pulmonary veins are draining into the left atrium, so there is no anomalous pulmonary venous drainage present. So this is the septal aneurysm. This is happening because the right atrium is putting all the blood to the left atrium. So there is definitely a big pressure there. And the right ventricle is already collapsed. So this is a complicated case. And you see this is a 28 to 29 weeks of single live intrauterine pregnancy with cephalic presentation. And there is a good amount of amniotic fluid. So there are so many fetal cardiac abnormalities, but the main finding or main culprit is the tricuspid atresia, which is causing the collapsed right ventricle. That's why there is also pulmonary stenosis as usual. We have a big pressure-like thing happening. So there is atrial septal aneurysm and mildly dilated aortic root to arch, and the pulmonary trunk is getting reverse flow, which is giving supply to the lungs. So what will you do in this patient? Will you continue the pregnancy, or you have to terminate? It's already 29 weeks. So it's a complicated situation. Okay. Whew, that's a big complicated case. Let's see another complicated case. So this is a 21-year-old male patient who came with a right anterolateral pulsatile neck lump. So that's the easy one, pulsatile neck lump, what it can be. So we hope that it will be an easy case, but unfortunately, it's not. It's a very rare case, I think. So here's the picture of the thyroid gland. I thought that there will be a thyroid gland or bronchial cleft cyst or something like that. Okay, what's that? So there's something here. Okay, the thyroid gland looks normal except for some cystic nodules or something like that. So let's look at the measurement. The isthmus looks quite normal. The overall thyroid measurement is quite normal, so we have nothing to complain about. There's the left lobe, and there is a tiny nodule here also. You may ignore it or you may report it. You can see colloid crystal casting cometal artifacts. So this is Tyreut's 1 lesion, so nothing to worry about. So on the right lobe, there was also a tiny cystic nodule, which is also not significant. These are Tyreut's 1 lesion. So nothing to worry about. So let's look at the main finding, which already we have seen at least a glimpse. So let's look at there. So this is the lump. You can see we have put the transducer over the lump. So this is a linear transducer view, high frequency view, and you can see swelling of the blood within this structure. So there is a movement, pulsatile movement going on here. So with this feature, you can easily say that this is a vascular lesion, definitely. Number two, it should be an aneurysm. Okay. So it would be good if this was the only diagnosis, but this is not the only diagnosis. We have to search a little more. So we need to search for the vessel connecting this aneurysm. It looks like a pseudo aneurysm. Okay, there is no history of trauma. So we expect it to be a congenital one, which is unusual. Traumatic cause is very common, but okay. So now the question is that it is connected to this vessel. So which vessel is that? So this is actually the internal jugular vein. So the aneurysm is pseudoaneurysm is connected to the internal jugular vein. This is very unusual to have this amount of flow from an aneurysm of internal jugular vein. So we are not satisfied. Let's see a little bit. So now here you can see this is the internal jugular vein, part of internal jugular vein, and there is a big flow going on here. You can see the swelling of the blood within this aneurysmal dilated part. Okay, that looks good. So we have put color Doppler. You can see very good amount of flow going and coming back. So we call it to and fro flow. Nowadays we call it bidirectional flow. So to say it as a bidirectional flow, you definitely have to use the pulse wave Doppler. So just think that on pulse wave Doppler, you'll see a flow going upwards, going downwards or something like that. Okay, we'll see that. Now here you can see this is structure. This is the common carotid artery at this part. So it is, I think, also getting some compression or something like that, whatever. So let's see the pulse wave Doppler. Here I have put the transducer at the central part. Now it's not a typical aneurysmal flow. You see, this is the venous-like or pulsatile-like flow. Okay. Yeah, there are some bidirectional wave here, but when I put a pulse wave Doppler sample, we take a pulse wave Doppler sample from the central part of an aneurysm, like this type of shape aneurysm, we see a very good bidirectional wave pattern, which is not present here. So that took another attention because I'm not satisfied with this type of flow. I want to see a very good bidirectional flow, but it is not present at the central part. So you should think about something else here also. Let's look at the view again. So this is a big aneurysm, like 3.7 centimeter at this part is a very dangerous situation because it will cause cardiac abnormality. Well, the cardiac function will be altered. So this is 3.7 centimeter maximum length aneurysmal dilatation of internal jugular vein. So this should be a pseudoaneurysm, whatever. Now let's look at the common carotid artery. So this is the common carotid artery. Ignore the aliasing because I'm not adjusting the structure. So, okay. So if you see the structure, aneurysm, you see the pulse of the internal carotid artery. It follows the pulse of the common carotid artery. So it follows the pulse of the common carotid artery. So you see both have similar pulsations. So that took our attention. Like, is there anything else we are going to miss? Let's see. So here you can see this is the common carotid artery. Okay, I have changed it a little bit. Now you see some flow is coming from the internal carotid artery and entering into the this aneurysm. Is it okay? Or I'm facing some illusion like thing. So that took my attention. Like it looks like the internal carotid artery is also supplying this lesion. Okay, so now I'm serious. So you see, this is the internal carotid, common carotid artery. Just ignore that error. So, okay, so you see, this is the internal jugular vein giving supply to the lesion. Okay, I'm satisfied. You see, let me freeze the image a little bit. So you see, this is the internal jugular vein giving connection to the aneurysm, and this is the common carotid artery. So this is the cross section. So yeah, it is not connected to the common carotid artery at this level. Okay, so just go a little bit backwards or downwards. You see the common carotid artery here. Okay, we're seeing the connection of the but here you can see some confusing area, like something is happening there. Let's see on different view. So you see the common carotid artery. This is the common carotid artery. Carotid artery. Oh, this is the common carotid artery. You see, just go a little bit backward. Now you see this is the common carotid artery supplying this aneurysm. Now what's going on? And now this is the common carotid artery, and this is the internal jugular vein. It is also connected to this aneurysm. So there is something abnormality, serious abnormality going on here. So this is the very complicated one. So this is the internal jugular vein connected, and you see this common carotid artery. Just see here, this is the aneurysm. Now here is the connection. You see this is the common carotid artery. Now this one is giving supply to the aneurysm also. So when you are seeing the arterial and venous connection here, so this should be counted as a fistula. So this is an arteriovenous fistula having aneurysmal dilatation. Now the problem is that it is getting supply both from the common carotid artery and internal jugular vein. These are precious vessels, so the situation won't be better for this patient. So, okay, so this is the internal jugular vein part. So this is the internal jugular vein connected to the aneurysm. And this is the common carotid artery. You see, this is the internal jugular vein, aneurysmal dilatation here. And you see, this is the common carotid artery, which is also supplying the area. So this is the internal jugular vein, and this is the common carotid artery. Both are connected to this aneurysmal dilated area. So we call it carotid jugular fistula. So aneurysmal dilatation of carotid jugular fistula you are seeing here. Okay, this is a very rare case, I think. This is my first case, so I'm not familiar with this thing. But it was enjoying. So this is the common carotid artery supplying the aneurysm. So that's why you are getting this type of pulsatile like flow within this aneurysm. So whenever you get an aneurysm, it is connected to the vein, whatever, but you see pulsatile flow like an artery, you should be careful because there might be an arterial communication. Okay, that's very crazy. So this is the arterial connection, just giving a very good swelling of flow. Okay, so this is the arterial one. So it's giving the supply, and this is the venous one. So both are connected in an aneurysmal way. So just a multiple view because it's a rare one. So I'm just trying to show you multiple views so that your eyes can detect it whenever you get that. So this is the common carotid artery, and this is the aneurysm, which is now connected to the internal jugular vein at this part. So let's check the pulse wave Doppler. Is it true that it's an arteriovenous fistula forming aneurysmal dilatation? So let's look at the sample. So if it is an arteriovenous fistula, the artery will show you a high velocity flow, and the vein will also try to show you an arterialization of the flow. Like venous flow will look like an artery. So if you look at the fistula side, like this is the arterial opening site, so common carotid arterial site. So here you can see a very high velocity flow, like more than 150 centimeter per second. Definitely there is some spectral broadening like thing, whatever. And this is the site from the internal jugular vein part. And this venous side or venous end is showing you arterial like flow. So this is the arterialization of the internal jugular vein site. That is the functioning fistula nature. Okay, so this is the arterial end, and now you can see a very rapid amount of flow. Even we have checked this part at the fistula part, there is a flow velocity of more than 300 centimeter per second even present. So very high rapid flow there. So this is the proximal part of the common carotid artery. where you see the velocity is increased because it's supplying the fistula. And this is the internal jugular vein part. It is showing the very good amount of arterialization of the flow. So this is the internal carotid artery and external carotid artery, which are showing a very speedy flow. So you see the velocity is slightly increased in the external carotid artery, not in the internal carotid, but still it is in a good amount of flow. So, and this is the internal jugular vein from different part, and you can see even it is the high up the neck. At the high up the neck, you can still see the internal jugular vein is showing a good amount of pulsatile flow. So the vein has turned into an artery-like appearance. So this is a case of aneurysm of the carotid jugular arteriovenous fistula at the right anterolateral neck. So you see the description I have given here, like the visible pulsatile swelling at the right anterolateral neck corresponds to a vascular aneurysm. This aneurysm is connected to the right common carotid artery proximally and the right internal jugular vein distally, so indicating an aneurysm of arteriovenous fistula. So the internal swelling of flow is seen on the gray scale. You have seen that. And the color Doppler shows internal to and fro flow. So the arterial end of the fistula show you a very high good amount of peak systolic velocity, and the venous end shows that amount of velocity. And the internal jugular vein spectrum has already turned into the arterialization pattern. So this is a case of carotid jugular aneurysmal fistula. Isn't it a very uncommon case? I think so. Okay, so tell me in the comment below. So thank you for joining me. So that's all for today actually. That's why I am not actually choosing any bonus part, because already they will make you toxic. So we have our next session, I think, on the Thursday. On February, we will make free sessions on Thursday, unfortunately, because on the Friday, we will use for our paid sessions due to some reason. I'll tell you a little bit later. So our next session possibly on the 6th February, Thursday, I hopefully post the schedule on that day. So don't get worried. And obviously, if you are from my own country, we have a paid session tomorrow. It will be on um our own language, so it's not suitable for the foreigners, unfortunately. So it will be on carotid Doppler. If you have missed it before, you can join there. Because our next carotid Doppler session will be, I think, on July, so it will be very late. So if you are free, you can join there. Okay, so here's the just approximate schedule of our February sessions. So on February, we are going to arrange a lot of webinars. If you see the red ones, these are the free webinars for the foreign persons, and others are only for the local persons, because these are paid and these are on our own language. So it won't be suitable for the foreigners, unfortunately. So we are taking a lot of webinars on this February, because I will close all my paid sessions on March and up to the mid of the April. So that's why it will be difficult to continue, because on March we have a Ramadan, so it's not a very suitable time to go for the paid sessions. And after Eid al-Fitr, I may take a little break for 1 or 2 weeks. So that's why up to April mid, I won't take any class. But yeah, on March, you will have many free sessions. Obviously, the ultrasound cases sessions like this. This will be available at 10 p.m. GMT on March. And yeah, I think we will upload many videos on YouTube also. So don't worry about that. But for February, we'll have a tight schedule, because these are of student demand, because they want it now. So I will just go for them, and then we'll take a long break of 1.5 months. So if you're new, or if you want this video fully to see, you can just go to the imaging study YouTube channel. You can get them. I will upload my this session tomorrow, I think, in my imaging study YouTube channel. So if you're not connected there, don't forget to subscribe, because why not? So we have a website which is very inactive, I think. We need to make them active. Okay, anyway. So thank you for joining me. If you have any question, you can just ask me in the live session. So I can just go and solve that. And don't forget to share. We don't see much sharing of these videos. Like if you find this helpful, if you find these cases interesting, maybe I'm not good to present, but this will be helpful, I think, for many of you who are not getting a proper exposure of this case. So don't forget to share it with your friends or in your groups or whatever. Don't worry, your sharing won't make us reach actually, because I have told you before that the amount of money I get from my YouTube area or something like Facebook, YouTube, or whatever in a year is usually less than what I earn in a week, actually. So that's why I'm not doing it for my business purpose, but our main aim is to share our content with you. When I was just around 10 years ago, it was difficult for me to learn from anyone. I tried to search many people to teach me, but it was very difficult to find people who want to share their cases. Now, in YouTube, you can find many beautiful persons sharing their cases. That's excellent. But at the time, it was a little bit difficult. So when right now I'm getting a lot of cases, why don't I want to share this with you? So that's why I'm trying to share because many parts of the world needs them. You may be privileged. I am also privileged to have many teachers and so many things, but in many parts of the world, it's very difficult. So that's why we are trying to share our cases with you. Hopefully, that will be beneficial. So let's solve a question. I have just missed it very far ago. Just let me check the question. Oh, so you are connected from very far away. Okay, many of you are connected from many different parts. That's crazy. That's crazy. Okay, so okay, the very important question and very difficult question is that how to locate the ovary uh, in a retroverted or antiverted, whatever. Tracing ovary in transvaginal sonography may be a little bit difficult sometimes. Yeah, it's true. It's true for all. But the way try to search for the ovary in transvaginal sonography, the easiest way is for me is to put the Doppler. I try to trace the fallopian tube area because the fallopian tube area will show you the vascularity because uterine artery is going there. So I trace that part with the Doppler, and then I try to find the ovary. That is the easiest way because at the end of fallopian tube, you'll get the ovary. So that's why if you can just put the Doppler, you can move the transducer to the lateral part a little bit, then just tracing the vascularity of the adnexa, you can search for the ovary. That is the easiest way for me, but it may be different for you. But still, ovary is very difficult. I found so many people complaining about searching for the ovary in TVS, so they find it very difficult. Thank you. Thank you. So many people from many part of the world is watching, so it's crazy and it's fun. Uh, Last year when I was in a different country, not from my country, I found some people, they actually doctors, they came to me and say that, do you have any YouTube channel named Imaging Study? Like I was very confused. I said with fear that, yeah, I have. There actually was that. So it's a very pleasant experience because they are from first world country and I'm from the third world country. So when I see them watching my video and they find it helpful, So it feels great. Okay. So at the time, I realized that we need to do something for many other people. Yeah. Thank you. We'll see you on Thursday, inshallah. Okay. We'll try for the LVOT RVOT on our any session. Okay, so we'll just try to put it on the our bonus part in any day. Okay, so our paid session about the scrotal ultrasound, I think, will be on the 25th February. So I'm just putting it a little bit later, just for some certain reason. Okay, so thank you for joining me. Hopefully, we'll meet again on our any free or paid session, whatever. So till then, thank you. See you on the next one. Have a nice day.